Hi, I'm Dr. Camille Dunkley. I will be discussing the neurobiology, screening, and diagnosis of opioid use disorder. This presentation is brought to you by Southern Illinois University Edwardsville and the Illinois Prescription Monitoring Program. The main objectives of this presentation are to review the neurobiology of addiction, review available screening tools for opioid use disorder, and to review the diagnosis of opioid use disorder. Addiction is a chronic relapsing condition. It is characterized by compulsive desires to take a drug despite the adverse effects, lack of control, and negative emotional state during periods of abstinence. This has changed over the years because historically, addiction was considered to be a moral failure or bad decision-making. However, research demonstrated that frequent drug use changes neuronal circuits involved in processing reward stimuli, behaviors, negative emotions, decision-making, and cognitive control. And these alterations can lead to severe behavioral disruptions. These changes are progressive, but once they develop, can persist years after drug use has stopped. It is important to distinguish between addiction and physical dependence. Physical dependence results in withdrawal symptoms when the substance is removed. However, compared to addiction, the symptoms are brief. Additionally, physical dependence is not characterized by a loss of control or continued use despite negative consequences. Lastly, physical dependence can be a class effect and observed with various medication categories, for example, antidepressants and beta blockers. There are several brain structures involved in the addiction process. The most common are the limbic system, the hypothalamus, the basal ganglia, and the frontal cortical regions. We will discuss these structures in more details throughout the presentation. The limbic system is characterized as a network of structures that transfers information between the cerebral cortex and the hypothalamus. It consists of the olfactory cortex, the hippocampus, amygdala, habenula, and the hypothalamus. It is involved in emotions, learning, and memory. Many illicit substances work within the limbic system, and research has shown that the neurochemistry within this area changes during the addiction process. The basal ganglia consists of the caudate, putamen, globus pallidus, ventral pallidum, and substantia nigra. It is located near the center of the brain. Its primary role is within the motor system, and it controls voluntary movement. It is also involved in decision-making, motivation, and memory. The connection between the limbic system and the basal ganglia has been studied in the drug reinforcement process. The insula is in the lateral sulcus, which separates the temporal lobe from the parietal and frontal lobe. It has an essential role in cue recognition, and with regards to addiction, can stimulate strong cravings for substances. Studies have found that individuals with nicotine dependence that have had damage to the insular region are more likely to quit smoking and remain abstinent. Executive function controls many aspects of behavior and can be severely impacted by the addiction process. It supports decision-making, setting and completing goals, and behavioral inhibition. The prefrontal cortex is at the center of executive function. It is divided into three areas: the orbitofrontal and ventromedial, which is involved in processing reward, the dorsolateral, which is involved in decision-making, and the anterior and ventral cingulate cortex, which is involved in behavior. The neurobiological model of addiction is composed of three different repeating stages: intoxication binge stage, withdrawal negative effect stage, and preoccupation anticipation stage. This model provides a comprehensive way to understand the signs of addiction and approaches to treatment and recovery. It is important to remember that all addictions are not the same. Each individual will have differences in the length and intensity of each phase. However, one universal similarity is that over time, the stages will become progressively worse, leading to more biological, social, and psychological harm. The intoxication binge stage of the addiction cycle begins when an individual uses a rewarding substance. This originates in the basal ganglia, which is located near the center of the brain and is a group of structures involved in motor learning, emotional behavior, and cognitive function. Additionally, the dopaminergic transmission rate increases, stimulating dopamine 1 receptors, which causes the euphoria or reward people typically describe in the initial stages of substance use. Taking a closer look at this reward system, there are two pathways that are activated. The mesolimbic pathway is responsible for positive reinforcement, which is mediated through the direct release of dopamine and opioid peptides. It involves communication between the ventromedial striatum and the nucleus accumbens. The nigrostriatal pathway is responsible for controlling motor function and behavior and involves the dorsolateral striatum. As substance use continues, an individual can develop more dopamine release from the reward stimuli, for example, certain people or places, than the substance itself. In these scenarios, anticipation of the use is separate from the use itself. This is called incentive salience, and it does not require conscious awareness. An example of incentive salience would be the wanting that occurs when a child walks past the window of an ice cream store. Regarding substance use, wanting can occur without the liking of the outcome or the use itself. And understanding this concept helps us to understand the importance of changing the people, places, and things associated with the substance use when treating an individual with an addiction. To summarize, the intoxication binge phase is characterized by the rewarding effects of drugs. There are large surges of dopamine release in the basal ganglia, which occurs at higher amount than natural reinforcers like food and sex. Additionally, natural reinforcers will lead to a state of satisfaction, while drugs of abuse do not. How each drug or illicit substance increases dopamine will be different. Cocaine, methamphetamine, and other stimulants increase dopamine by inhibiting reuptake in the synaptic space or promoting release in the cytoplasm, while opioids, alcohol, and nicotine work both directly and indirectly to modulate dopamine self-firing. Now we will discuss the withdrawal and negative effects stage. There are two primary neuroadaptions that characterize this phase. Neuroadaptation 1, there is decreased dopamine tone in the nucleus accumbens, increased glutamate tone in the reward system, and decreased GABA tone in the reward system. Overall, this decreases the euphoria from the reward, decreases stress tolerance, and increases feelings of agitation. The second neuroadaptation results from higher recruitment of stress circuits in the brain. This occurs in the amygdala, and there is increased release of stress mediators like dynorphin, corticotropin releasing factor, norepinephrine, and orexin. The overall clinical consequences of these neuroadaptations are irritability, anxiety, and depression. Additionally, there is decreased satisfaction from natural rewards like interpersonal relationships, food, or sex. And the need to remove these negative feelings in the withdrawal phase can cause a person to increase substance use in the intoxication phase. However, over time, taking more substances to overcome withdrawals can worsen withdrawal symptoms in the next period of abstinence. In summary, the withdrawal and negative affect phase reflects the loss of reward, decreased motivation, and enhanced sensitivity of the brain stress system. This is experienced as dysphoria, loss of interest, and irritability. During this phase, there is a transition from impulsive to compulsive use, and the neuroadaptations that were previously discussed are the primary drivers of the compulsion. This leads to increased substance use, which is further reinforced by the relief of withdrawals. The next stage in the cycle is the preoccupation anticipation stage, and this occurs during periods of abstinence. It involves the prefrontal cortex, which is responsible for executive functioning. However, brain imaging studies have demonstrated that decreased density in this area is associated with a shorter relapse time. And in severe substance use, this could essentially mean a couple of hours. This phase is generally characterized by cravings. In summary, the preoccupation and anticipation phase is characterized by impulsivity, decreased executive function and inhibition, and the loss of control over the amount and frequency of substance use. It is caused by injury to the prefrontal cortex from the chronic drug use, and this worsens the addiction cycle. Next, we're going to discuss the behaviors associated in the addiction cycle. For example, impulsivity, reinforcement, and compulsivity. Initial substance use is characterized by impulsivity, meaning sensation seeking is coupled with the need for urgency and the potential negative outcomes are not fully considered. Positive reinforcement can make an individual more likely to reuse the substance. Positive reinforcement can also be associated with the social stimuli instead of the substance itself. For example, peer approval or drinking alcohol socially. However, these reinforcing effects can decrease over time with repeated use and can result in more frequent or increased substance use to achieve the original effect. This is also known as tolerance. Using substances to avoid withdrawal symptoms primes the change from impulsive to compulsive behavior. This marks the loss of decision-making over substance use and is a sign of addiction. In many cases, compulsive behavior has a central role in the barriers individuals face when they try to abstain from drugs. Genetics play a pivotal role in the neurobiology of addiction. It is estimated that there is a 40 to 70% heredity component in these disorders. The genes impacting the cycle of addiction include dopamine, glutamate, GABA, and opioid peptides. Epigenetics, or nurture, regulates how specific genes are expressed or silenced in response to environmental factors and stressors like drug exposure. And understanding this gives us the potential to develop new treatment models. Environmental factors associated with an increased risk of substance use are lower socioeconomic status, poor parental support, peer group influence, and drug accessibility. Normal behavior during adolescence can be marked by risk-taking, seeking originality, sensitivity to peer pressure, and increased experimentation. This reflects incomplete brain development and connections. Even though this experimentation during this stage of development has been normalized, both animal and human studies have shown that chronic drug exposure during this period increases vulnerability to substance use disorders later on in life. The risk of substance use disorder in individuals with mental illness is significantly higher than the general population, likely due to overlapping environmental, genetic, and neurobiological factors. For example, approximately 30% of individuals with a psychiatric disorder will present with a substance use disorder at some point during their lifetime. Another example is depressed individuals with co-occurring alcohol use disorder have more severe suicidal symptoms compared to depressed individuals who do not drink alcohol. Also, depression can decrease someone's motivation to maintain abstinence from a substance. This is clinically significant and underscores the importance of screening and treatment when managing either of these conditions. Inflammation also has an interesting role in addiction. Chronic substance use can trigger an immune response within the brain, leading to neuroinflammation, neural dysfunction, worsening cravings, and increase the risk of relapse. And addressing this inflammatory component in addiction can also increase the possibility of developing novel treatment options. There are several challenges regarding addiction that still need to be addressed within society. Firstly, recognition and consensus on addiction as a chronic disease, stigma, social policy, and limited treatment options. Also, in many cases, individuals with substance use disorders are isolated from their families and communities, which can increase isolation and negatively impact the recovery process. Next, we are going to discuss screening for opioid use disorder. In 2022, there was more than 81,000 opioid-related overdose deaths in the United States. In that same year, close to 4% of adults aged 18 and older met the criteria for opioid use disorder treatment. However, only 25% of them received medications. And most adults who qualified for treatment either didn't perceive that they needed it or received treatment without medications. There are several epidemiological differences between substance use and gender, age, ethnicity, family history, and socioeconomic status. We will discuss a few of them next. Differences between men and women regarding alcohol and substance use has been attributed to several factors, such as societal standards or cultural norms, metabolism, and body size. The prevalence and incidence of unhealthy alcohol consumption, alcohol use disorder, and substance use disorders are higher in males than females. However, this gender gap is narrowing. The highest prevalence and incidence of substance use is in late adolescence and young adulthood. Early onset of drug use is associated with increased risk of developing a substance use disorder. Regarding alcohol specifically, early drinking onset is associated with alcohol-dependent symptoms, increased risk of alcohol-related injuries, motor vehicle accidents, violence after drinking episodes, antisocial behaviors, and increased level of drinking in response to stressors. Information on the relationship between alcohol and drug use and racial or ethnic background is inconsistent, likely due to limited data, discrepancies in the classification of ethnic groups, and other confounding variables like socioeconomic status. Studies have demonstrated that employment status is related to alcohol and substance use. In 2016, the National Survey on Drug Use and Health found that full-time employed individuals were more likely to report consumption of alcohol in the prior month than unemployed individuals. However, there was no difference in binge drinking or heavy alcohol use. Regarding use disorder or addiction, however, there was a higher prevalence of alcohol use disorder or alcohol-related mortality in individuals who were unemployed. This study also found a higher prevalence of illicit substance use reported in unemployed or part-time individuals. It is important to note that the temporal relationship with this data is difficult to determine. The temporal relationship between marital and substance and alcohol use is difficult to determine. Studies have found that people in stable marriages have the lowest 12-month prevalence of alcohol use disorder. Also, the lack of marital stability or periods of transition, for example, divorce or widowhood, are associated with increased substance use. Studies assessing the relationship between genetics and substance use disorders have found evidence for heritability with caffeine, cannabis, cocaine, nicotine, and opioids. There are several tools available to assess the risk for opioid use disorder, and they should be used in combination with clinical examination and urine drug screening. A standardized approach has been shown to be superior to a subjective assessment and should include a biological, social, and psychological assessment. The Opioid Risk Tool was published in 2005. It is a 5-question survey used to assess the risk for developing opioid misuse or opioid use disorder in an individual not currently receiving long-term opioid therapy. The score is used to predict low, moderate, or high risk. A score of 0 to 3 is low risk, 4 to 7, moderate risk, and 8 or higher is considered high risk for developing opioid misuse. The ORT is widely used because it's accessible and easy to perform. Studies have demonstrated the sensitivity to be between 18 to 75% and the specificity to be between 50 and 80%. The Screener and Opioid Assessment for Patients in Pain revised version was published in 2008. It is a 24-question tool designed to assess the risk for opioid misuse before long-term opioid treatment has started. Each question is scored 0 to 4. The total score ranges from 0 to 96, and a score of 18 or higher indicates high risk for misuse. This tool is validated, but has a lower sensitivity than other available assessments. The current opioid misuse measure was published in 2007. It is a 17-question tool designed to identify aberrant or irregular behaviors while a patient is receiving chronic opioid therapy. Each question is scored 0 to 4. The total score ranges from 0 to 68, and a score of 9 or higher is suggestive of aberrant or atypical behavior. The sensitivity of the tool is over 70% and the specificity over 60%. This tool is validated. Another validated tool that can be used when a patient is on chronic opioid therapy is the Patient Medication Questionnaire, which was published in 2004. It is a 26-question survey that also assesses aberrant or atypical behavior. Each question is scored 0 to 4. The total score ranges from 0 to 104, and a score of less than 25 is considered low risk. A score between 25 and 30 indicates problematic use, and a score higher than 30, there should be some consideration for tapering the patient off of opioids. The sensitivity for this tool is around 35%, and the specificity is close to 80%. Opioid use disorder is defined as the chronic use of opioids that causes significant impairment. Symptoms include an uncontrollable desire to use opioids, increased opioid tolerance, and withdrawal symptoms when opioids are absent. OUD is similar to other health conditions in that there are intervals of exacerbation and remission, long-term treatment adherence can be difficult, and the risk of relapse can occur throughout an individual's lifetime. The Diagnostic and Statistical Manual of Mental Disorders, 5th edition, determines the diagnosis of opioid use disorder. There are 11 criteria that assess the physical and social impairments associated with opioid use, starting with opioids are taken in larger amounts than intended, there is a desire to cut back and attempts that have been made have been unsuccessful, excessive amount of time is devoted to obtaining or recovering from opioid use, there is a strong desire to use opioids despite the negative effects, there can be a failure to fulfill obligations at home, work, or school, there is continued opioid use despite having negative relationship effects, social and recreational activities are given up to use opioids, there is continued opioid use despite putting oneself in danger, there is continued use despite having negative physical or mental health effects, there is a need to use more over time to get the same effect, also known as tolerance, and withdrawal symptoms occur if opioids are abruptly discontinued or no longer available. It is important to note that tolerance and withdrawal are signs of physical dependency and can occur without the other OUD criteria, meaning that an individual prescribed chronic opioid therapy for pain management can have withdrawals if opioids are discontinued abruptly and may require dosage increases to maintain the same level of pain control. However, these signs alone do not make the diagnosis of opioid use disorder if the individual does not have any other criteria. The presence of 2 to 3 diagnostic criteria indicates mild opioid use disorder, 4 to 5 indicates moderate opioid use disorder, and 6 or higher indicates severe opioid use disorder. Typically, medication management is indicated for moderate or severe opioid use disorder. The differential diagnosis for opioid use disorder includes chronic pain, untreated mental health conditions, and other substance use disorders. It is important to evaluate for these conditions while diagnosing OUD. To summarize this presentation, the neurobiology of addiction model involves several different brain areas and can be characterized by 3 different stages in the cycle: intoxication, withdrawal, and preoccupation. Genetics, nurture, and neuroinflammation also play important roles in addiction. There are several different screening tools available for opioid use disorder and can be incorporated into practice. However, diagnosis is confirmed utilizing the DSM-5 criteria. Thank you for listening.